Here's my ID. I'm going to scan my room. So the first thing that I would do is verify orders and hospital policy. And then I would compare, then I would perform hand hygiene, and then I would compare the patient's armband to the patient's chart to verify identity. I have Jaguar Jones, date of birth 8/25/63, 8/25/63, medical record number 417, 6352, 6352, and then I would verify the allergies and compare it to the allergy band. I have allergies penicillin, and then I would ask the patient if they have any other allergies that I need to know about. And then I would evaluate the essential conditions that justify the use of an indwelling catheter. For example, to assist in healing of open sacral or perineal wounds in incontinent patients, for patients with acute ventilator-dependent respiratory failure, or for palliative or end-of-life care. And then I would explain the procedure to the patient and pull the curtain to provide privacy. I've already gathered my equipment, and then I would don my goggles. And then I would position the trash can close to the patient's bed, perform hand hygiene, and then I would raise the bed to a working height, lower the side rail, and position the patient in the dorsal recumbent position. I don't know if you can tell, but these are supposed to be my patient's legs. And I would have the legs slightly bent and ensure that they are wide enough apart that I have adequate workspace. I would also be working above waist level because this is a sterile procedure. And then I would don my clean gloves and perform perineal care using soap and water. So for both a male and a female patient, I would wash and dry the upper thighs. And then for a female patient, I would ensure that I always clean from front to back. So I would use a new section of a washcloth each time that I clean. So I would first wash the labia majora. I would wash one side, use a separate section, and then wash the other side. And then I would retract the labia from the thigh. And I would use a separate section or a clean washcloth and wash the skin folds on one side, use a separate section or a clean washcloth and wash the skin folds on the other side. And then I would rinse and dry. And then I would retract the labia, and I would use a clean washcloth, and I would wash the urethral meatus and the vaginal orifice. And I would wash one time in one sweeping motion, and I would use a clean washcloth or a new section of the washcloth each time that I wash until it is clean, and then I would rinse and dry. For a male patient, I would, if they were uncircumcised, I would gently retract the foreskin, and I would use a clean washcloth, and I would wash the urethral meatus in a circular motion outwards. And I would do this with a clean washcloth each time until it is clean, and then I would rinse and dry, and I would place the foreskin back into its natural position, and then I would wash the shaft of the penis and the scrotum. I would have the patient abduct their legs and gently lift the scrotum and wash the underlying skin folds, and then rinse and pat dry. So then after performing perineal care, I would open my catheter tray, and it would not be all messed up like this, but I've used it so much. So I'm going to show you how I would open it. So go like this, and then I would remove these gloves and everything that I dispose of would be discarded above waist level. And then I would perform hand hygiene. And now I'm going to contaminate and move over here so you can watch me don my sterile gloves. So I would open the package. Okay, now I'm going to contaminate again and move back over here. Okay, so then I would place my sterile field I would place it shiny side down. And then if I needed to adjust, I could touch it in the middle, but make sure that I don't touch the 1-inch border because it is not sterile. And then I would place my tray, and then I would open my betadine Q-tips. I'm not going to be using them though. I'm going to pretend that these are my betadine Q-tips. And then I would open my lubricant. I would squirt it on the tray, discard, and then I would open, take the cap off of my saline, and then I would connect it to the balloon port, and then remove the cover on the catheter, and then I would lubricate the catheter 1 to 2 inches for female or 5 to 7 inches for male. And then I would take, and I would use my non-dominant hand. I'm actually right-handed, so I'm doing this backwards, but I can make it work. I would retract the labia, and I would take my betadine Q-tips. I would wash one side of the labia and discard, and I drop one of my Q-tips. Normally, that should not happen. And then I would wash the other side, discard, and then go one sweep down the middle, and then discard. And I would ensure that my hand remains on the patient, retracting the labia, because if it closes, then that would be contamination and I would have to start all over. For a male patient, if they were uncircumcised, I would gently retract the foreskin and I would clean the urethral meatus in a circular motion outwards. And I would do that 3 times with the betadine Q-tips. Now I'm going to insert the catheter, and I would instruct the patient to bear down as if they were voiding, or they could take a breath and exhale on insertion. So I would insert the catheter until I see urine. So I see urine, and then I would advance the catheter 1 to 2 inches for a female, and then all the way to bifurcation for the male. So then I would hold the catheter in place, and then inflate the balloon. And then unscrew, and then I would discard. Then I would gently tug on the catheter until I felt resistance, and then I would advance slightly. That is to take pressure off of the bladder stem. And then after that, I would take the lure lock, or not the lure lock, the stat lock, sorry. And I would open it. And then place it, and it would be like this. And then to remove it, you just unclip and take it out. And before placing the stat lock on the patient's thigh, I would use the skin prep pad that comes in the package, and that is according to hospital policy, according to what you use to prepare the skin. And then I would place it to the patient's thigh, and I would use this clip here to clip to the patient's bed. And then I would take and hang the drainage bag to the bed frame and not the bed rails. And I would ensure that it is below the level of the bladder and that there are no dependent loops. So now I'm going to contaminate, and I'm going to show you a specimen collection for a catheter that was just inserted. So let's set this on, and I will get my specimen cup. I would have a towel on the floor, and this is my graduated cylinder. I would have that on the floor, and I would take my specimen cup, and then I would take this, I shouldn't have hit that, I would take this out, and then I would unclamp it, and then let it drain into the specimen cup, and I would ensure that I don't touch the inside of the specimen container. And then I would reclamp, insert it back, and then I would place the cap on the cup, and then I would label and send it to the lab. And you always place the label on the outside of the container, never on the lid. So now I'm going to contaminate again. I'm going to move back up here and show you the procedure for specimen collection for a catheter that has been in for perhaps several hours or several days. So what you would do is clamp the catheter, and then you would take a alcohol pad or whatever your hospital policy designates, and you would clean the port right here with the alcohol pad and then allow it to dry. And then you would take a 10 milliliter Lure-Lock syringe. I don't have one, so I'm going to just use this syringe. And then you connect it and then withdraw the urine and then place it into the specimen cup. Again, ensuring that you don't touch the inside of the specimen cup. And then you would dispose, place the cap, place the label, and then send it to the lab. So then you would be sure to unclamp the tubing. Okay, so then I would clean up my mess. I would remove my gloves and perform hand hygiene, and then I would position the bed in the lowest position, raise the side rail, ensure the call light is within reach, and make sure the patient has anything that they may need. And then I would move on to documentation. I would document the size of the catheter tube, the amount, color, and consistency of the urine, the patient's tolerance to the procedure, and also if there was a specimen collected. And I would have plans to discontinue the catheter as soon as medically indicated. And for daily catheter care and for after incontinence of stool, you would of course provide perineal care like normal, and then you would use a clean washcloth and you would clean the catheter itself. So you would start close to the urethral meatus and then you would clean 4 inches along the length of the catheter, and you would do that in a circular motion. So you would clean outwards. So then, for discontinuing the catheter, of course, you would verify the patient's identity and check the chart and do all of that again. And you would explain the procedure to the patient. And you would empty the drainage bag using the graduated cylinder, and then unclip from the patient's bed, and then remove the stack lock. So you would unclip, and then you would take a 10 milliliter syringe and loosen the plunger, and then pull it back to 1/2 of a milliliter, and then insert it into the balloon port and allow it to drain by gravity. Well, mine came out. Okay. Now, ensure it to let it drain by gravity. Okay, so then you would disconnect, and then you would pull the catheter out, and then discard, and then you provide perineal care like you normally would, and then you would move on to documentation. We document the color, amount, consistency, and the odor of the urine, the intactness of the catheter tip, how much water was removed from the balloon port, the patient's tolerance to the procedure, and you would also document patient teaching. So I would teach the patient the symptoms of a UTI. UTI symptoms could be pelvic pain, it could be pain with urination, it could be burning, it could be blood in the urine. There could also be an increased urgency to urinate. And then after teaching the patient, I would also be sure that I note the time of the removal of the catheter, and with plans to assess the patient for voiding within 4 to 6 hours. Again, that's according to the hospital's policy. And if the patient has not voided, then I would palpate the bladder and or obtain a bladder scan. So I believe that is it.